All right, today we're going to dive deep and really crack the code on one of the most common and critical events in respiratory medicine, and that's the acute exacerbation of COPD. It's common, it's critical, and we need to know it inside and out.
You know, for the millions of people living with COPD, this is a constant fear, right? That familiar feeling of breathlessness, that cough that just won't quit. But the real question is, when does a typical bad day cross that line and become a genuine, life-threatening emergency? That is the question we're going to tackle right now.
And that line, that's what we call an acute exacerbation of COPD. So to really get a handle on this, we're going to follow a patient's journey, step by step. We'll go from those first worsening symptoms all the way through diagnosis, treatment, and maybe most importantly, how to prevent it from happening again. By the end of this, you're going to have a solid, clear framework for managing this whole critical event.
Okay, so first things first, what exactly is a COPD exacerbation? Let's nail down a clear definition and use a really simple analogy to make sure this concept sticks.
So here's the official definition. We're talking about an acute worsening of respiratory symptoms. Things like dyspnea, which is just shortness of breath, cough, and sputum. And the key here is that it goes beyond their normal day-to-day ups and downs. This isn't just a bad COPD day. Nope, it's a real significant decline that happens in under 2 weeks. And usually there's a trigger, like an infection or even air pollution.
I love this analogy because it makes it so easy to picture what's going on. Imagine your lungs are a system of highways. In healthy lungs, those highways are wide open, air flows easily. Now in chronic COPD, the highways are always a little congested, right? Traffic is slower, but it's still moving. But in acute exacerbation, that's a full-blown multi-car pileup. Inflammation and mucus just flood the airways, causing a complete traffic jam. Air can't get out, and suddenly the person just can't breathe.
Okay, so we've got the what down. We understand the traffic jam. Now, how do we spot it? How do we diagnose this crisis quickly and accurately when a patient walks through the door?
Well, it really boils down to what we call the 3 cardinal symptoms. These are the classic signs you need to look for. First is their shortness of breath, their dyspnea, noticeably worse than their baseline. Second, are they producing more sputum, more phlegm than they usually do? And third, and this one's a big one, has that sputum become more purulent? Meaning, has it gotten thicker or changed color to something like green or yellow? Getting a handle on these 3 symptoms is absolutely key, because it guides our entire approach from here on out.
All right, so we've figured out what's happening. We've identified an exacerbation. But the next super critical question is, how severe is it? Because the answer to that question is going to dictate everything we do next. Where we treat the patient, what treatments we use, the whole shebang.
Now here's a really important way to think about severity. It's not just about how bad the symptoms seem. The GOLD classification actually defines it by the treatment the patient needs. So, mild means they just need their short-acting bronchodilators, their rescue inhaler. Moderate means we're stepping it up with antibiotics and/or oral corticosteroids. And severe is simple. It means they need to be in the hospital or the emergency department. That's it. It's a really practical, treatment-based way to classify things.
And when we talk about severe, there are some major red flags you have to look for. These are the signs that scream, this patient is in trouble. Are they using their accessory muscles, those muscles in their neck, just to take a breath? Are you seeing paradoxical chest wall movement, where their belly sucks in when their chest goes out? Is there any new or worsening central cyanosis? Are their lips turning blue? Are they confused or less alert? Any one of these is a huge sign of major respiratory distress, and it tells you they need a higher level of care, right now.
Okay, so we've diagnosed the crisis, we've figured out how severe it is. Now it's time to intervene. Let's talk about the pillars of treatment, the core things we do to clear that traffic jam in their lungs.
Our acute management strategy really rests on 3 main pillars. Pillar number 1, bronchodilators. We give them short-acting bronchodilators to try and force those airways open. Think of this as trying to clear one lane on that congested highway. Pillar 2, corticosteroids. We hit that massive inflammation hard with systemic steroids, something like prednisolone at 40 milligrams a day. This is like calling in the crew to clear the wreckage from the pileup. And pillar 3, antibiotics. We use these when we think a bacterial infection is part of the problem.
Now, when it comes to those steroids, there's actually a bit of a debate in the medical community. How long should the course be? The big GOLD guidelines, they point to the reduced trial and recommend a short 5-day course. But then you have other major guidelines, like from the ERS and ATS, that suggest a longer course, up to 14 days, might be better, especially for patients being treated at home. It's a good example of how evidence evolves, and it's something you definitely need to be aware of.
So what about that third pillar, antibiotics? When do we pull that trigger?
Well, thankfully, we have some pretty clear rules. You give antibiotics if the patient has all three of those cardinal symptoms we talked about. Or you give them if they have two of the symptoms, but only if one of them is that increased sputum purulence, that thicker, colored phlegm. That purulence is really our best bedside clue that a bacterial infection is driving this. Oh, and one more thing. If a patient is sick enough to need mechanical ventilation, either invasive or non-invasive, they get antibiotics. Period.
But look, for some patients, everything we've talked about so far for outpatient treatment, it's just not going to be enough. So how do we make that call? How do we know when it's time to escalate care and admit them to the hospital?
This is probably one of the toughest questions a clinician faces in this situation. When does that standard treatment just not cutting it? This is the point where we have to start thinking about things like respiratory failure and whether the patient needs a higher level of support.
And that brings us to non-invasive ventilation, or NIV. There's a really clear evidence-based checklist for when to start this. The decision is driven by the data. Are they developing respiratory acidosis? So if you check their blood gas and the pH is 7.35 or less and their PaCO2 is 45 or higher, that's a trigger. It means they're not blowing off enough carbon dioxide. Other big triggers are severe dyspnea with signs that their respiratory muscles are just getting tired out, or if their oxygen levels stay dangerously low even after you put them on supplemental oxygen.
Okay, and when do we go even a step further and consider the ICU? Well, ICU admission is for the sickest of the sick. We're talking about patients whose breathing is getting worse despite everything we've tried, including NIV. Or if there's a big change in their mental status, they're becoming confused or lethargic. Other triggers are persistent worsening hypoxemia or a really severe respiratory acidosis, like a pH under 7.25. And of course, if they need invasive mechanical ventilation or they're hemodynamically unstable, meaning their blood pressure is crashing and they need vasopressors, they absolutely need to be in the ICU.
All right, let's fast forward. Our patient has been treated, they're starting to stabilize, that's great. But the journey is far from over. Honestly, getting them home safely and making sure they stay home is just as important as all the acute treatment we just talked about.
And a safe discharge isn't just about opening the door. It's about going through a checklist. Has the patient been clinically stable for at least 12 to 24 hours? Has their need for that rescue SABA inhaler come way down to maybe every 4 hours or even less? Can they do basic things like walk across the room if they could before? Can they eat and sleep without getting severely short of breath? And this is huge. Do they and their caregiver actually understand how to use their medications correctly? Have you set up their follow-up appointments? Ticking all these boxes is crucial to preventing that revolving door of readmissions.
Which brings us to our final section. And you could argue it's the most important part of this whole story. How do we break the cycle? How do we stop this from happening all over again?
Well, if you want to break the cycle, you first have to understand what causes it. And if you look at the data on primary triggers, one thing just jumps out. Look at that biggest slice of the pie: viral infections. Things like the common cold, rhinovirus, or influenza. For most of us, it's just a nuisance. But for a person with COPD, it can be the spark that ignites a life-threatening exacerbation. And knowing that, well, it tells us exactly where to focus our prevention efforts.
And here's what that prevention strategy looks like. Number 1, today, tomorrow, and forever, is smoking cessation. It is the single most important intervention, period. After that, knowing that viruses are such a huge trigger, vaccinations become absolutely non-negotiable. We're talking influenza, pneumococcal, COVID-19, RSV, Tdap, all of them. Then we have to make sure their daily long-acting inhaler therapy is optimized and they know how to use it correctly. We should get them into pulmonary rehab within a few weeks of being discharged to help rebuild their strength. And finally, patient education. We need to give them an action plan and teach them how to spot the earliest warning signs so they can act fast next time.
So let's leave it with this final thought. An acute exacerbation, it's not just some random, unlucky event. More often than not, it's a failure of chronic management. It's a sign that something in our long-term plan wasn't working. So whether you're a doctor, a nurse, a patient, or a family member, the real question to ask yourself is this: what is the one change you can make starting today to help prevent that next pileup? What can you do to keep those highways clear?